Welcome back to the deep dive. Today, we are undertaking a deep dive into infusion therapy, which sounds simple. It's just hanging a bag, right?
Well, maybe not quite that simple.
But in medical surgical nursing, this is actually the most common invasive procedure administered to patients, and getting it wrong can instantly trigger, well, some really serious complications.
That's exactly why we're here.
Yeah.
Our mission today is basically to distill the core knowledge you absolutely need for safety and competency when you're administering parenteral fluids and medications.
Okay.
And to organize this quite complex material, we're going to focus on two non-negotiable patient priority concepts that really govern everything here: fluid and electrolyte balance
Right.
and tissue integrity.
Because fundamentally, every single time we start an IV, we're either, adjusting the patient's fluid balance, delivering critical drugs, or maybe replacing blood products.
Exactly. And our goal is always safety first. That always begins with understanding the chemistry of what we're actually putting into the bloodstream.
Okay, so let's start there. The chemistry.
Let's start with the fluids themselves and this concept of tonicity. Tonicity is essentially how concentrated a solution is compared to normal human serum.
Okay. And normal is what range?
Usually sits somewhere between 270 and 300 millimoles per liter, or osml.
Got it. So that gives us our three main categories then. You have isotonic solutions, which sit right in that normal range.
And those are really designed to stay in the extracellular space, simply expanding the patient's volume without causing major fluid shifts in or out of cells.
Then you have hypertonic solutions. Those are the ones above 300 milliosml.
Correct. They have a higher concentration of solutes, so they actually pull water out of the cells and into the vascular space.
And the opposite, hypotonic solutions below 270 milliosml, they do the reverse, right? Pushing water into the cells.
Exactly, to hydrate the cells or, expand them.
So what's the critical clinical insight here thinking about that first priority, fluid and electrolyte balance, especially with isotonic fluids?
Well, the big risk with isotonic solutions, precisely because they stay outside the cells in the vascular space, is if you administer them too rapidly.
Ah,
Especially, say, to an older adult who might have underlying cardiac or renal issues, you dramatically increase the risk of fluid overload.
right, because their system just can't process that sudden volume expansion. It stays right there in the vessels.
They just don't have the reserve to handle all that added fluid staying entirely within the vascular system. It makes perfect clinical sense.
Okay, now let's connect this to our second priority, tissue integrity. When does the fluid itself become dangerous to the actual vein wall?
It really comes down to extremes of chemistry. Solutions become highly damaging when they have an extreme pHo, maybe less than 5.0 or more than 9.0,
Okay.
or when they are super concentrated, hyperosmolar, with an osmolarity greater than 600 millimL. Those characteristics are basically precursors for phlebitis and thrombosis,
Yeah.
vein damage.
And when we talk about solutions being highly concentrated, I mean, the classic example that comes to mind is total parenteral nutrition, TPN. Those must have really high osmolarity.
Oh, they absolutely do. TPN solutions often clock in at over 1,400 millimL.
Wow, 1400.
Yeah. I mean, put that in perspective. That's almost 5 times the osmolarity of normal blood serum.
So trying to infuse something like that into a tiny peripheral vein.
It's like injecting syrup, essentially. It absolutely guarantees vein damage.
So the rule is pretty much non-negotiable then. Anything that potent must be infused centrally. Why is central infusion the answer?
It's all about the blood flow. The superior vena cava, where the central line tip sits, has a massive rate of blood flow.
Okay.
That incredibly high flow provides rapid, adequate hemodilution. It instantly dilutes that concentrated TPN solution as it enters the bloodstream, and that protects the vessel wall from chemical damage.
Makes sense. Now, beyond just the concentration of the base fluid, we also have to differentiate between specific drugs. We use terms like vesicants and venous irritants. What's the key difference there for tissue safety?
The key difference is really the level of destruction if they leak out of the vein. A venous irritant, maybe like vancomycin or amiodarone, causes inflammation phlebitis if it leaks. It's bad, but manageable.
Okay, inflammation, but a vesicant.
A vesicant, like certain chemotherapies or vasopressors like dopamine, is catastrophic if it leaks.
Catastrophic how?
If a vesicant infiltrates the surrounding subcutaneous tissue, we call that extravasation. It causes severe blistering, tissue death, actual necrosis. It's basically a chemical burn from the inside out. It can become a surgical emergency fast.
So if the nurse sees any early signs of infiltration, maybe swelling, coolness at the IV site, or the patient starts reporting pain or a tingling sensation, the action alert is immediate, right?
Absolutely immediate. You have to stop the drug infusion right away, remove the catheter, and notify the provider or the infusion team. Delaying this risks significant, potentially permanent tissue loss.
Okay. Before we move on to the actual hardware, the catheters themselves, let's just touch on one final safety point: blood administration. The sources mention the Joint Commission's national patient safety goals have strict procedures here.
Yes, they do. For blood administration, it requires 2 qualified professionals checking everything
2 people.
and verifying using 2 separate positive patient identifiers. Plus, what really underpins that accountability is the ISPT Universal Bar Coding System.
Ah, the bar coding.
That system requires 4 essential pieces of info right on the label. The unique ID of the facility that processed the blood, the original donor lot number, the specific product code for what's in the bag, and of course the ABO and RH type. That level of detail is absolutely critical for preventing transfusion errors.
That definitely sets a high standard for accountability. Okay, now let's talk about the hardware we use to deliver these solutions. Vascular access devices, or VADs. This is where the engineering kind of meets the patient.
Right. And the guiding principle for selecting a VAD ties directly back to tissue integrity. We have to choose the smallest gauge catheter that's capable of delivering the prescribed therapy effectively,
Smallest gauge possible.
while also considering how long the therapy will last, the patient's overall vascular health, and any existing comorbidities.
Because while, say, a big 18-gauge catheter allows for really rapid flow, maybe for surgical trauma, it also causes more trauma and inflammation to the vein itself than a smaller 20-gauge would.
Precisely. A 20 gauge is generally adequate for pretty much all standard therapies.
Yeah.
But yeah, for rapid infusion or major surgery, we might step up to the 18 gauge.
And the smaller ones.
Conversely, the smaller 24 or 26 gauge are usually reserved for very fragile veins, maybe in infants, small children, or some older adults.
Okay. For the most common device we see, the short peripheral catheter, the SPC, I understand we've moved away from routine site rotation. The dwell time is now based on clinical signs.
Yes, that shift is a really key clinical insight. We now remove the SPC only when there's a specific indication of failure, like signs of phlebitis, infiltration, or if it's just not working properly.
So we're minimizing unnecessary sticks.
Exactly, minimizing venipuncture and trauma. But for ongoing safety, we still need to assess that site frequently, at least every 4 hours for most adults.
Then more often for some.
Yes, for vulnerable patients, maybe the critically ill, or those who are confused or nonverbal, that assessment frequency really needs to be bumped up to every 1 to 2 hours.
Got it. When choosing a site for an SPC, what are the absolute best practices we need to stick to?
Okay, always aim for the upper extremity if possible. Start distal, like in the hand or forearm, and only work your way proximally if you need to retry.
Makes sense.
We definitely avoid areas of joint flexion, like the wrist or elbow crease, because movement can dislodge it or cause infiltration. And absolutely avoid any arm affected by a mastectomy, a dialysis fistula, or paralysis. Critically, also avoid any vein that feels hard, cord-like, or is tender when you palpate it. That usually means the vein's already stressed or thrombosed.
And what about that critical rescue point for insertion? I remember reading about one specific danger zone that must be avoided.
Yes. You absolutely must avoid the palmar side of the wrist, the underside. The median nerve runs very close to the surface and the veins there.
Oh, okay.
So the patient reports any tingling, burning, or numbness during the insertion attempt. That strongly suggests a potential nerve puncture.
What do you do then?
You stop immediately. Remove the catheter, apply pressure, and try a completely different site. Never, ever risk permanent neurological injury just to get that IV started.
Good advice. That brings us to the intermediate duration devices, the midline catheters. How are these different from a standard SPC?
Midlines are longer, typically about 3 to 8 inches. They're inserted into the upper arm, usually the bilic, cephalic, or brachial vein, and the tip rests no farther than the axillary vein, so it doesn't go all the way to the central circulation.
Okay, and they're for longer use.
Right, they're designed for therapies lasting maybe 6 to 14 days. But here's the crucial nuance, the really important part. Midlines are still considered peripheral devices.
Meaning they still have limits on the kinds of fluids or meds they can handle, chemistry-wise.
Exactly. If the infusate is a known vesicant, if it's TPN or if it's a solution with an extreme pH or very high osmolarity, stuff we talked about earlier, you absolutely cannot use a midline. They just don't provide the level of hemodilution needed to prevent vein damage from those harsh solutions.
Okay, so for those high-risk solutions or for really long-term needs, we have to shift to central intravenous therapy using CV aids, and the location of the catheter tip is critical here.
It absolutely is. The tip must reside in the lower third of the superior vena cava, SVC, ideally close to the cavil-atrial junction, CHA, where the SVC meets the right atrium.
And you have to confirm that placement.
Mandatory. Confirmation of that tip placement is required before you can use the line. Traditionally, that's done via chest X-ray.
But there are newer ways, too.
Yes, newer technologies like using ECG guidance during placement or magnet tip locators are becoming more common as well. But confirmation is key.
Okay. The most common type of long-term CVAD seems to be the PICC line, right? Peripherally inserted central catheter. These seem to handle pretty much anything, including that high osmolarity TPN we discussed.
They do. Because that tip is centrally located in the SVC with its massive blood flow, the rapid hemodilution takes care of any harsh chemistry. So there are really no limits on the pH or osmolarity of what you can infuse through a PICC.
So they're used for.
Long courses of antibiotics, chemotherapy, vasopressors, TPN, often for therapies lasting longer than 14 days, sometimes months.
When managing PICCs, what's the non-negotiable safety rule about the syringe size you use for flushing? And why is that pressure limit so important?
This is a big one. You absolutely must use a 10 milliliter barrel syringe or larger for flushing a PICC.
Only 10 milliliters or bigger. Why?
Because the physics of smaller syringe barrels, like a 3 millimil or 5 milliliter, generate excessive pressure per square inch when you push the plunger. That high pressure risks rupturing the catheter tubing itself.
Ah, okay, so 10 milliliter minimum.
Always. We also counsel patients with PICCs to avoid excessive physical activity or heavy lifting with that arm, as forceful movement can potentially lead to catheter dislodgement or damage.
Good point. And then we have implanted ports, which seem like the ultimate long-term solution.
They really are. Ports are placed entirely under the skin, usually in the chest wall, in a small subcutaneous pocket. They're designed for therapies expected to last more than a year, like intermittent chemotherapy.
And accessing them requires a special needle.
Yes, they are accessed using a specialized, non-coring Huber needle. That needle design prevents damage to the port septum. And a critical safety alert for drug administration via port, you must always check for and obtain a blood return before infusing any drugs.
Especially vesicants.
Especially vesicants. If you don't get a brisk blood return, you have to assume the needle placement might be incorrect or the port access is compromised. You withhold the vesicant to prevent extravasation into the subcutaneous pocket, even though it's technically a central device.
Got it. Better safe than sorry.
Absolutely. And finally, just a quick note on hemodialysis catheters. They have massive lumens designed for the very high flow rates needed during dialysis.
Okay.
Generalist nurses should not use these catheters for routine IV infusions or medications, except perhaps in a true life-threatening emergency when no other access is available. They also require careful aspiration of the heparin or citrate locking solution from each lumen before any use.
Okay, that covers the hardware pretty thoroughly. Let's move into Section 3, daily nursing management. This is where we really implement those safety strategies day to day. It starts right with the prescription itself. What makes a complete safe order?
A complete prescription absolutely has to include the specific type of fluid.
Okay.
The administration rate, usually in ml per hour or sometimes volume over a specific time.
Right.
And the specific drug, dose, and frequency if a medication is being added. A really serious patient safety issue is the use of incomplete or ambiguous prescriptions like TKO or KVO to keep vein open.
Why are those bad?
Because those terms don't specify a safe therapeutic rate. What does keep open mean? 10 milliliter, 25, 50. It's imprecise and leaves room for error or potential fluid overload. It's not a complete order.
And luckily, technology has given us some safety nets here in the form of smart pumps.
Yes, smart pumps are a huge advance. They use integrated dosage calculation software and institution-specific drug libraries with DoseGuard technology.
How does that help?
Well, they're designed to reduce adverse drug events, or ADEs, by basically flagging the nurse if the programmed dose or rate falls outside the preset safe limits defined by the hospital pharmacy for that specific medication.
Sort of a double check.
Exactly, a technological double check.
Okay, now on a more granular level, every single time we access the IV system, we're potentially introducing infection. OSHA mandates needleless connectors, but that doesn't entirely solve the problem, does it? we still need to vigorously scrub the hub.
Oh, absolutely. That's critical. Blood, bacteria, biofilm.
Yeah.
They can easily get trapped in the tiny crevices of the luer lock connection port.
So just a quick wipe isn't enough.
Definitely not. The evidence is clear. We must scrub the hub vigorously, using friction, for at least 10 to 15 seconds with an appropriate antimicrobial agent, usually alcohol or chlorhexidine,
Yeah.
before every single time we connect anything to that port.
10 to 15 seconds every time. Got it. Now, the highest level strategy for preventing systemic infection is the CRBSI Prevention Bundle Catheter-Related Bloodstream Infection. This seems paramount for maintaining tissue integrity systemically, preventing sepsis.
It absolutely is. This evidence-based bundle has several major components, and honestly, every nurse involved in infusion therapy should know them by heart.
What are they?
Okay, it includes things like proper aseptic hand hygiene before any contact, using maximal barrier precautions during the actual insertion of central lines, sterile gown, gloves, mask, large drape,
Right.
using chlorhexidine for skin antisepsis at the insertion site, selecting the optimal site, which usually means avoiding the femoral vein in adults if possible due to higher infection risk.
Okay.
And then the crucial ongoing step, daily review of line necessity. Does the patient still absolutely need this central line today?
That daily review, that's where the human element, the critical thinking comes in. We have to actively ask, is this line still essential? If the answer is no, then prompt removal is actually the best infection prevention strategy.
Precisely. And we can kind of summarize much of the local site care and infection prevention with the HANDS mnemonic.
Yes.
Yeah. H for hygiene, A for antisepsis, N for no-touch technique when accessing torts, D for documentation of site condition and care, and S for scrub the hub. HAND.
That's a handy one. Okay, once the VAD is placed, it needs to be secured properly. Using dedicated securement devices like a stat lock or something similar helps prevent VAD movement, right? Which is a major precursor to phlebitis and infiltration.
Absolutely. Proper securement is key for maintaining tissue integrity. And dressing changes have specific timelines, too. Standard gauze and tape dressings need to be changed every 48 hours,
Okay.
whereas transparent membrane dressings, like Tegaderm, are changed typically every 5 to 7 days, or sooner if they become soiled, loose, or damp.
And a final safety note for dressing removal, especially with central lines. I remember reading something specific about how to pull the dressing off.
Yes, this is important. When removing an old dressing, especially from a central line, you should gently pull the dressing laterally, sort of parallel to the skin, or towards the insertion site. Never pull away from the insertion site perpendicularly,
Why not?
because that outward pulling motion creates tension that significantly risks accidentally dislodging the entire central catheter. Pull sideways or towards.
Got it. And of course, if the nurse ever notices that the external length of the catheter has changed, more or less sticking out than before, that's an immediate flag, right? Call the provider.
Immediate notification. It means the tip location inside the body may have moved, which could be dangerous. Needs reassessment.
Okay, let's finish this section by quickly visualizing the two most common local complications, phlebitis and infiltration. How are they graded?
Okay, phlebitis, which is inflammation of the vein, is graded on a scale, usually 0 to 4. Grade 1 might just be some redness and maybe slight pain at the site.
In grade 4.
Grade 4 is the worst. You've got a visible streak of redness up the arm, a palpable venous cord. You can actually feel the hardened vein for more than an inch, and often purulent drainage. That's a significant inflammatory response, possibly infection.
Okay. And infiltration, where the non-vesicant fluid leaks into the surrounding tissue.
That also progresses, usually graded 0 to 4. Grade 1 might be just some blanched, cool skin and maybe edema less than an inch around the site.
And grade 4 infiltration.
Grade 4 infiltration is characterized by skin that's very tight, maybe even leaking clear fluid. It could be discolored or bruised. There's severe pain, and potentially circulatory impairment to the extremity. And remember, if a vesicant solution infiltrates, it's automatically considered a grade 4 event extravasation, regardless of the initial appearance, due to the high risk of tissue necrosis.
Right. That distinction is critical. Finally, we should briefly mention a systemic complication risk specifically associated with central lines, air embolism.
Yes, this is a potentially lethal, though thankfully rare, complication. It's a risk primarily when changing administration sets or if the catheter disconnects or breaks.
How do we prevent it?
We manage intrathoracic pressure during those high-risk moments. You place the patient flat, or even better, in the Trendelenburg position, head down.
Okay.
If the patient is awake and can cooperate, you ask them to perform the Valsalva maneuver, basically. Hold their breath and bear down right at the moment you disconnect the old set and connect the new one.
And if they can't?
If they can't cooperate, you try to time the set change to coincide with the expiratory phase of their breathing cycle. Both maneuvers increase intrathoracic pressure, which helps prevent air from being sucked into the large central vein during that brief moment of disconnection.
Got it. Okay, let's look at our final section. Specialized patient populations and alternative infusion routes. The older adult population often presents unique challenges related to both tissue integrity and fluid and electrolyte balance, right?
They absolutely do. In terms of tissue integrity, older adults often have thinning, more fragile skin and decreased subcutaneous fat.
Mm-hmm.
This makes them much more prone to skin tears during tape removal or even from the tourniquet.
Okay.
Their veins can also be more superficial and more likely to roll. So management-wise, we often try to avoid the very fragile veins of the back of the hand if possible. Maybe start a bit higher on the forearm.
And the insertion technique?
Use a lower venipuncture angle, maybe just 10 to 15 degrees because the veins are closer to the surface. And you can even place a washcloth or gown sleeve under the tourniquet to cushion the skin and prevent tearing.
Good tips. And for fluid balance, the risk for older adults is kind of twofold, isn't it?
It really is. On one hand, they are highly susceptible to fluid overload because of potential underlying cardiac or renal changes that reduce their ability to handle excess volume. But on the other hand, they can also become dehydrated more easily, so vigilance is absolutely key. And importantly, we must make sure VAD sites are always visible for assessment, even if we have to use special netting or sleeves to secure lines on a patient who might be confused. You can't assess what you can't see.
Very true. Okay, now for some alternative routes. Beyond standard IV therapy, we sometimes use subcutaneous infusion or hypodermolysis. What's that?
This is a slow infusion of isotonic fluids directly into the subcutaneous tissue, usually the abdomen, thigh, or upper arm. It's primarily used for mild to moderate dehydration, often in palliative care settings, when oral intake isn't sufficient and IV access might be difficult or undesirable.
But it's not for emergencies.
Definitely not for emergency volume replacement.
Yeah.
The absorption is slow, and the maximum infusion rate is typically quite low, around maybe 120 milliliters per hour.
Okay. For true emergencies where IV access is impossible, we sometimes turn to intraosseous therapy or IO.
Right. IO access involves inserting a special rigid needle directly into the marrow cavity of a bone, often the proximal tibia in adults or children.
Why there?
Because the bone marrow has a rich vascular network that provides rapid access to the central circulation. It's a very fast way to get fluids and emergency drugs into the system when peripheral IVs fail, like in trauma or cardiac arrest.
But it's short term.
Very short term. IO access is typically used for less than 24 hours. Prolonged use carries risks, most notably compartment syndrome in the affected limb if fluid extravasates under pressure.
Okay. Finally, the highly specialized routes, intraarterial and intraspinal.
Right. Intraarterial lines are placed directly into an artery, usually the radial artery. They're most commonly used for continuous blood pressure monitoring in critical care, or sometimes for targeted delivery of chemotherapy to a specific organ or region.
And the critical rescue alert here.
Because it's arterial access, the absolute critical rescue alert is that all connections must be Luer-Lock devices that screw tightly together. Accidental disconnection of an arterial line can lead to rapid catastrophic hemorrhage. And you have to monitor the affected extremity very closely for signs of impaired perfusion, like coolness, pallor, or loss of pulse.
Makes sense. And for intraspinal infusions, like epidural or intrathecal routes, used mostly for pain management or treating CNS cancers.
The absolute non-negotiable safety necessity here is that any medication administered via the intraspinal route must be explicitly labeled preservative-free.
Why is that so crucial?
Because common preservatives found in multi-dose vials like benzyl alcohol are neurotoxic. They must never be introduced directly into the cerebrospinal fluid or epidural space, as they can cause severe neurological injury or paralysis. Preservative-free is mandatory.
Wow, okay. This has been a really dense but incredibly important dive into infusion therapy conflicts. So for the learner listening, wrapping this up, what are the absolute key takeaways focusing back on our two core concepts?
Well, first, VAD selection is critical and must be appropriate for the solution's properties, its tonicity, pH, osmolarity, and the planned duration of therapy. That protects tissue integrity.
Right.
Second, strict adherence to the CRBSI prevention bundle is non-negotiable for infection control, again protecting tissue integrity systemically. Third, maintaining local tissue integrity means rapid recognition and immediate management of local complications like phlebitis, infiltration, and especially extravasation.
And for the other concept?
And maintaining fluid and electrolyte balance means vigilant monitoring of those infusion rates, using smart pumps correctly, ensuring orders are complete, and recognizing the unique vulnerabilities of certain populations, like older adults, to fluid overload or dehydration.
That covers it well. Now, we talked about how modern systems like smart pumps definitely increase safety by handling calculations and guarding doses. But what's the sort of enduring challenge for the nurse, for us, as these technologies become even more widespread?
That's a really fascinating and ongoing challenge that comes up in the evidence base. As technology, like smart pumps, continues to automate safety checks and reduce certain types of errors, the nurse must consciously fight against becoming, well, desensitized or overly reliant on the device.
Complacent, maybe?
Exactly. We absolutely must maintain our own manual dose calculation skills.
Mm.
We need to ensure our critical thinking remains sharp enough to question or validate alarms, to recognize when the technology might be wrong, or when the patient's clinical picture doesn't match what the pump is telling us. We need to be ready to override technology errors when our clinical judgment dictates.
So the safety isn't just in the tech.
No. The ultimate safety net is still the human critical thought process backing up the technology, not replacing it.
That's a truly important point for anyone entering this field or practicing in it. Thank you so much for taking this deep dive with us today.
My pleasure.